Good morning, everybody. It's a pleasure to welcome you to Grand Rounds. I'm hoping that some of the attendees online will be able to participate, and hoping more people will arrive here at the lecture theater. It's a great pleasure to introduce our speaker today, but before I do, I just want to make a land acknowledgement. So we acknowledge that we're grateful to live and work and play on the traditional and ancestral and unceded territory of the Coast Salish people. Today's presenter is a new faculty at UBC, but not new to UBC, as he's been both an undergraduate and a postgraduate student here in internal medicine and cardiology. Nima reminded me that we met each other in 2012. It's been a long road. It's 2024. Nima's actually just completed 2 years in Duke and has now returned to UBC. And today he's going to talk to us about the contemporary strategies in the management of acute heart failure. Nima?
Thank you so much. Thank you so much, Dr. Kassan, and thank you to everyone who's here in person and online. It's a great pleasure of mine to be back at UBC, seeing all of you and be presenting on the ground rounds today. So as Dr. Kassan said, I'm one of the new faculties here, and my practice mostly focuses on heart failure, transplant, and cardiac critical care. I have no disclosures to say, but as Dr. Kassan said, I feel like I'm back home, so I owe a little bit of life update in terms of what I've done. As you know, I've been at UBC for 10 years, doing all my medical training here. And then life took me to North Carolina. I went to Duke in 2022 to do some additional training in cardiac ICU and heart failure and transplant. And then this guy happened in North Carolina. So we were Americanized, and we were full Blue Devils fans. And until my friends from UBC sent me this onesie saying, UBC cardio, team cardio, and that made me realize how much I miss family home in Vancouver and UBC. So we decided to come back just 3 months ago, and we're all happy again. We're smiling, we're walking beside Seawall. So thank you for having me. This is the outline of my talk. I'll talk a little bit about the incidence of acute heart failure in Canada. I want to talk a little bit about decongestion strategies in acute heart failure, how we can optimize medical therapies during an acute heart failure, and touch on implementation strategies to improve our in-hospital care in patients with acute heart failure. And lastly, talk about something that I'm passionate about in terms of referral for advanced heart failure therapy. So what is the incidence of acute heart failure? As we all know, heart failure is a growing epidemic. It's on the rise in Canada. More than 750,000 Canadians are living with heart failure. More than 100,000 Canadians are diagnosed with heart failure every year. And more than 10,000 Canadians die from heart failure each year. And 1 in 3 Canadians' lives have been touched by heart failure. And heart failure costs our healthcare system a lot, more than $2.8 billion per year. And hospital admissions for acute heart failure have also increased over time. In Canada, there was around 45,000 admissions for acute heart failure in 2013. And that number is expected to be increased by 20% to 54,000 patients in 2030. And it is estimated that the cost of heart failure admission as a primary diagnosis would substantially increase by 50% by 2030 to about $720 million. So acute heart failure is common, it's increasing in prevalence with rising hospitalizations and associated with significant costs. But despite the significant advances that we've had in medical therapy and resources for heart failure care, there's been minimal improvement in heart failure outcomes. Here I'm showing some data from the Canadian Cardiovascular Society Heart Failure Quality Improvement Working Group, looking at the 30 days hospital readmission and length of stay for acute heart failure across Canada. And what we see here on the left-hand side is that the 30 days readmission rates have remained essentially unchanged from 2019 to 2018 in Canada, with similar patterns of high readmission in British Columbia. So our volumes of heart failure hospitalization has increased, but our readmission rates, unfortunately, have not changed, provincially and nationally. Similarly, as you can see on the table on your right-hand side, our length of stay for an acute heart failure has remained stagnant, hovering around 7 days for over a decade now. So why are these numbers alarming? That's because there's a pronounced rise in mortality with an acute heart failure episode. More than 1 in 10 people die within 30 days of an acute heart failure event. And from those who get to be discharged, more than 1 in 5 are readmitted. So with the first episode of acute heart failure, your 30-day mortality is 12% and your 1-year mortality is 34%. And as you can see, on the figure from your right-hand side, the mortality increases with repeated episodes of acute heart failure decompensation, almost doubling with second admission as seen in the red curves and tripling with your third admission. So the first kind of point I want to talk about is that how can we decongest acute heart failure patients effectively? So to answer that question, we have to understand how do patients with acute heart failure present. Patients come into hospital because they are congested, not because they feel like their creatinine is up or their blood pressure is lower. So congestion is just not a nuanced symptom, but is the primary reason for heart failure hospitalization in 85% of patients. This is a neat study from Duke University using data from ESCAPE trial where they stratified patients based on their cardiac index and pulmonary capillary wedge pressure. And what they observed was that cardiac index was not predictive of adverse outcomes, but congestion, as reflected by your pulmonary capillary wedge pressure, was associated with mortality, hospitalization, or need for advanced therapy. So ultimately, what this means is that fluid or congestion is more important marker of disease than flow or cardiac index in your acute heart failure patients. And I think of congestion as an entity that is routinely hidden or missed by us in clinical practice. This is data derived from implantable hemodynamic monitors, suggesting that congestion is the primary reason for acute heart failure decompensation event, and it is often under-recognized, preceding an actual hospitalization episode by days or weeks. As you can see here, filling pressure, as estimated by your pulmonary artery diastolic pressure obtained from cardiac MEMS implantable hemodynamic monitor devices, continues to rise several weeks prior to time zero, when a patient actually develops symptoms and have a decompensation event requiring hospitalization. And this is true for both patients with HFpEF and HFrEF. So the first focus of acute heart failure management should be on decongestion. And one of the primary recommendations about heart failure management emphasizes early decongestion. And one of the supporting documents for early decongestion comes from this study from emergency department registries, where they looked at 1,300 acute heart failure patients treated with IV diuretics. And they specifically looked at the time between presentation and administration of IV diuretics and outcomes. And what you can see here is that the risk of in-hospital mortality is nearly threefold in all cohort of patients when they receive their IV diuretics in a delayed fashion, that is beyond 60 minutes of presentation. We also looked at the relationship between early decongestion as a function of door to furosemide time in our Canadian heart failure registry. Yeah. Oh yeah, I think they did, yeah. Canadian heart failure registry of patients admitted to a hospital with acute heart failure. We didn't observe the same mortality benefit with early decongestion as it was observed in the prior study, but we found a non-statistically significant trend towards decreased hospital length of stay with shorter door to furosemide time. So the first question around decongestion management, that now that we talked about early decongestion, is how to dose diuretics. And a lot of you here know about this trial, the dose trial. This was the landmark dose trial where patients were randomized in a 2x2 fashion to high versus low dose IV Lasix or bolus versus continuous infusion. And they defined high dose IV Lasix as 2.5 times of your home oral dose, and low dose IV dose being the same dose of your home oral dose. And they found there was no difference in death, rehospitalization, or emergency room visits in high versus low or bolus versus continuous Lasix infusion. But what dose trial also showed that we sometimes do not talk about is that with higher dose diuretics, there was a greater weight loss, greater net volume loss, greater reduction in your natriuretic peptides, and a trend towards improved symptoms. but this was at the expense of worsening renal function. So if you look at the renal function endpoints in dose trial, as we talked about, there was a non-statistical trend toward worsening creatinine and significantly higher incidence of worsening renal function in patients in high dose arm. So when you review this data, then your first response is that, you know what, snap, high dose diuretics are bad. But is worsening renal failure really a bad sign when you're trying to decongest patients? And interestingly, in the post hoc analysis of the dose trial, worsening serum creatinine was not associated with increased adverse outcomes. On the contrary, a linear increase in serum creatinine was paradoxically associated with improved outcomes more than those patients who had improved renal function, as shown in your left figure. And additionally, no subgroups of patients who had worsening renal function with diuretics had increased risk of adverse events. So worsening renal function in setting up interventions that are otherwise beneficial in acute heart failure, such as aggressive diuresis, may have limited prognostic importance. Another question that comes up routinely in our clinical practice is that when patients are not responding to loop diuretics, or otherwise we call them diuretic resistant, is that should we give them metolazone or augment with thiazide? And this is data for 14,000 heart failure admission in Connecticut, United States, of which there was an 8% use of metolazone as an adjuvant diuretic therapy. And in this propensity and multivariate adjusted analysis, what you can see here was that metolazone was associated with increased risk of hyponatremia, hypokalemia, and worsening renal function. And on the lower end, you see that metolazone was actually associated with higher mortality compared to high-dose loop diuretics. So there's more decongestion that happens, but there's going to be at a cost. And more recently, last year in 2023, chlorotic trial was presented, which is one of the few randomized studies of thiazides in acute heart failure, where they looked at addition of high-dose hydrochlorothiazide to intravenous furosemide in 230 patients in a double-blinded fashion. It included patients with both HFrEF and HFpEF, and across the spectrum of phenotypes of heart failure. So patients received hydrochlorothiazide around 25 to 100 milligrams dosed by their renal function. And what they saw was that there was a greater amount of weight loss in 5 days, greater amount of diuresis with hydrochlorothiazide augmentation, but no significant difference in patient-reported dyspnea. There was, however, an increased incidence of impaired renal function with thiazide, but no difference in serious adverse events, including mortality. So what about high-dose spironolactone to augment diuresis? That's something that we kind of commonly do in our clinical practice. We put them on spironolactone to augment diuresis. And there has been some pilot studies suggesting use of spironolactone in addition to loop diuretics in assisting with diuresis and maintenance of potassium balance. But this was studied in a randomized fashion in only few instances, including the Athena HF trial, which was a study of 360 patients with acute heart failure and stage 3 or 4 chronic kidney disease who were randomized to high-dose spironolactone at 100 milligram daily in addition to their IV loop diuretics versus placebo or a low-dose spironolactone. And high-dose spironolactone was not effective at improving your NT-proBNP levels or any other secondary outcomes such as dyspnea, urine output. However, the incidence of renal dysfunction was not increased with high-dose spiro. So high-dose spironolactone, even at high doses, may not be as effective as diuresis as we previously thought, but is safe in terms of renal endpoints to give to patients. More recently, the ADWORD trial was published, which got a lot of interest and buzz in the heart failure community and overall, I think, our general medicine community regarding use of acetazolamide or Diamox in people with acute decompensated heart failure. And as you know, acetazolamide works at the proximal convoluted tubule as a carbonic anhydrase inhibitor. So what ADWORD did was that randomized 519 patients with both heart failure reduced ejection fraction and heart failure preserved ejection fraction to IV acetazolamide at a dose of 500 milligram IV daily for 3 days, or placebo in addition to standard loop diuretics. And there was a positive results for a primary endpoint with 46% more decongestion. defined as absent signs of volume overload at 72 hours with acetazolamide with a number needed to treat of 8.5. There was also half a liter more a day of diuresis and greater natriuresis with acetazolamide augmented diuresis. And there was no difference in adverse events. There was a little bit of increased incidence of renal dysfunction, but non-statistically significant. So there might be a role for acetazolamide in diuresis in our acute heart failure patients. How about SGLT2 inhibitors for augmenting diuresis? We seem to be doing that a lot, these days. And this is what DICTATE-AHF trial looked at. Results were just recently published a few months ago in April. DICTATE-AHF looked at 240 patients with acute decompensated heart failure, and they randomized within 24 hours of presentation to dapagliflozin or placebo in addition to the standard IV loop diuretic protocol. And they found dapagliflozin had a strong signal to improve diuretic efficiency supported by greater weight loss than that just missed statistical significance with a p-value of 0.06, increased total urine output per 40 milligram of IV furosemide that you give your patient, and decreased time to hospital discharge. So what this showed was that early dapagliflozin initiation was safe in acute heart failure and actually helped decongest and augment your diuresis in patients. So how does these adjuvant diuretic therapies pan out or compare to one another? And this was an interesting pilot study that compared the decongestive effectiveness of dapagliflozin versus metalazone. They randomized 61 patients, small number with acute heart failure resistance to IV loop diuretics, to receive an add-on diuretic, either dapagliflozin or metalazone. And the primary outcome was weight loss and congestion score. And interestingly, they were not statistically significant between patients receiving dapagliflozin or metalazone. However, the dapagliflozin group required a higher total dose of furosemide. On average, in the span of 5 days, they required 260 milligrams of more IV furosemide compared to the metalazone group. So the diuretic efficiency is lower in SGLT2 inhibitors than metalazone. But despite the use of more furosemide, decongestion with dapagliflozin was achieved with less incidence of hypokalemia, hyponatremia, and smaller increases in creatinine than with metalazone group. And this is in keeping with the hypothesis that SGLT2 inhibition would cause less kidney dysfunction, electrolyte disturbances than metalazone if we use it as an adjuvant diuretic. I want to talk a little bit about tolvaptan, which is an oral vasopressin 2 antagonist that inhibits the action of antidiuretic hormone, which leads to the loss of free water and results in aquaresis. When I was doing my training there, I always joked that we use tolvaptan like candy. Everyone who was a little bit hyponatremic, we give them tolvaptan. And we don't have it readily available in clinical practice in here in Canada, although, in special situation, you can get your hands on it. We recently got compassionate care for a patient who was admitted here at SVH St. Paul's CICU who, had significant diuretic resistance and hyponatremia, and we were able to give them tolvaptan. So what tolvaptan does in terms of the evidence for it, this was studied in the TACTIS-HF trial. This was a study of 257 patients who were admitted with acute decompensated heart failure, and they were randomized to tolvaptan versus placebo on the background of conventional diuretic therapy with IV Lasix. And the primary outcome was improvement in dyspnea, which was not different between the placebo and tolvaptan group. However, the tolvaptan was associated with significantly more greater weight loss, fluid loss, and improvement in your serum sodium, especially in your patients who are struggling with hyponatremia and ongoing volume overload. So talking about sodium, I want to talk a little about other strategies to monitor our diuretic response outside urine output and daily weights. And, we all work, been into general medicine wards, cardiology wards, and we know it's impossible to get an accurate measure of your urine output or weights in hospital. So in patients with acute heart failure, recent studies have linked low urine sodium concentration with reduced diuretic response and ongoing congestion. In this kind of neat study from Belgium, the investigator evaluated whether urine sodium concentration could be used to identify patients with chronic heart failure at risk of hospitalization. So they had 80 patients with chronic heart failure to submit weekly pre-diuretic sample of urine sodium for 30 weeks. And as you can see, patients were stratified in two groups, those with low urine sodium excretion in the light gray bars, and those with high urine sodium excretion in the black bars. And they saw patients who were admitted with acute heart failure had actually lower urine sodium concentration. And why is that important? It's because we can use this concept of urine sodium to guide our diuretic therapy. Dr. Testani, who is a great leader in terms of diuretic therapies at Yale, developed this natriuretic response prediction equation to actually predict urine sodium output using a spot urine collected 2 hours after your IV loop diuretic administration. And in this proof of concept study, they used this equation that I highlighted here to guide their inpatient diuretic therapy. So in 160 patients in the Yale diuretic pathway, you can see that the urine sodium guided strategy led to increase in total urine output, net urine output, and weight loss with acceptable safety trends in terms of renal function and electrolytes. Therefore, there's been some call, amongst many specialists for emerging pathways in titrating your diuretic dosing in acute heart failure. And one proposed pathway relies on your urine sodium. So if a particular diuretic dose doesn't produce your adequate natriuresis, this is reflected as a low spot urine sodium. And this should trigger a reaction by the treating provider to increase the dose of loop diuretic. So if a patient is on Lasix infusion, it is pretty easy. You can check your random urine sodium. If you're doing intermittent Lasix dosing for the best estimation of your natriuresis, you need to check the spot urine sodium 1 to 2 hours after dose, which again, I appreciate it's hard to do in our busy medicine floors as well. And one of the recent contemporary randomized trials that looked at this natriuresis-guided therapy in acute heart failure was PUSH-AHF trial that was just published 2 years ago. This was a single center study in Netherlands of 310 acute heart failure patients requiring treatment with IV loop diuretics, and they were randomized to natriuresis-guided therapy or standard of care. So in the natriuresis-guided therapy, or the urine sodium was measured at certain time intervals after the IV loop diuretic administration. And diuretic treatment was intensified if your urine sodium was less than 70 after administration of IV loop diuretics. And the co-primary outcome of natriuresis at 24 hours was statistically higher in the intervention group. However, the all-cause mortality or heart failure hospitalization at 180 days was not different between the two groups. So although the natriuresis was improved if we follow our urine sodium, the clinical outcomes did not improve. And more recently, this concept of urine sodium and guiding diuresis was tested in the ENACT-HF study that was just published again a few months ago. This was an open label study of 400 patients randomized to standard of care and a diuresis protocol using urine sodium where dose of IV diuretics were to be escalated if your urine sodium was less than 50. And what they found was that using a urine sodium guided protocol, you have 64% increase in your natriuresis and increased diuresis over 2 days. And they actually showed that they can decrease your length of hospital days by 1.3 days if you adopt a urine sodium guided strategy. There's also some recent interest in using hypertonic saline diuretic resistance. And this is, against the central mantra, we believe in heart failure that salt is bad. But there are multiple hypotheses that why hypertonic saline can increase your diuretic efficiency. High osmotic property of hypertonic saline, allows shifting of your fluid from extravascular volume to the intravascular volume. It can actually reduce your RAS activation, and it can correct your hypochloremia. And we don't think about chloride in our practice, but actually chloride is quite important in terms of diuretic resistance because it regulates your diuretic sensitive tubular sodium transporters. And hypochloremia has been causes adverse effects, including RAS activation. And in a recent study of 58 patients with acute decompensated heart failure refractory to IV loop diuretic, hypertonic saline administration was associated with increased diuretic efficiency, with increased total urine output, fluid, and weight loss, and improvement in your metabolic derangements and serum sodium with no adverse respiratory or neurological signals. So this is, again, I would say, contemporary approach to diuretic therapy in acute decompensated heart failure. Patient gets admitted, I usually double their dose of home diuretic, give it as IV. If they're diuretic naive, I start with 40 or more milligram of IV, depending on the renal function. That doesn't work. I double the dose, start Lasix infusion, but I start, if I can, following their urine sodium. So if I give a dose, I check their urine sodium an hour or two after. If it's not doing anything, if the urine sodium is less than 50, that's a signal for me to intensify and double my treatment. If my urine sodium is more than 50, that means that I'm probably doing a good job on diuresing the patient adequately. And if I've kind of reached the limits of my loop diuretics, then I kind of reach for my adjuvant therapies. And these days I use acetazolamide quite frequently. 500 milligram IV times 3 days is mostly kind of transient that I use it. And the best treatment effect is actually in the Edward trial is patients who had a baseline alkalosis with a bicarb levels of more than 27. Or, I reach for SGLT2 inhibitors and kind of use it in patients, again, who are eating and there's no history of kind of genital mycotic infections. I don't use them together because they work kind of in the same kind of proximal convoluted tubes, and the Edward trial, the SGLT2 inhibitor use was excluded. I sometimes use spironolactone in my kind of diuretic resistance patients, not because of their decongestive effect, but mostly it kind of because it helps with your kind of potassium balance if you're using high dose loop diuretics. And in kind of really diuretic resistant patients who are also hyponatremic, I do reach out for hypertonic saline. And kind of the dose I use is I give 150 mils over 30 minutes up to 3 days. Or if you can really get your access to tolvaptan, I use that up to 3 days. Again, these are transient measures. And one thing with hypertonic saline, I usually like to do it in ICU or in HAU setting, just that because patients need monitoring, in terms of their neurological status after the dose you give them. So then I'm going to move in terms of when and which medical therapies to start in acute heart failure. I think majority of our audience here knows about guideline-directed medical therapy for chronic heart failure patients. And in our chronic heart failure patient, we strive to put them on quadruple therapy with ACE, ARB, or preferably ARNI, beta blockers, MRAs, and SGLT2 inhibitors. For HFrEF and for our heart failure preserved ejection fraction, our GDMT includes SGLT2 inhibitors, MRA, specifically recently the non-steroidal MRA with finerenone, and some degree our Entresto. But how about using these medications in acute heart failure stage? As we all know, one of the foundational paradigms in acute heart failure is modifying our neurohormonal adaptation. But we are always worried about guideline-directed medical therapy initiation in heart failure patients in hospital, especially with beta blockers. Although beta blockers should never be initiated in a patient in a decompensated state or shock, early studies with beta blocker use in hospital, as shown here in the optimized HF study, showed that more than 50% lower mortality and rehospitalization with in-hospital beta blockers start after the initial stabilization compared to eligible patients with heart failure who were not treated with beta blocker. And this is similar to finding a worsening outcomes if you withdraw the beta blocker after the patient present to hospital with acute heart failure. So what about in-hospital initiation of ACE or ARB in acute heart failure? If we look at the data from the GET with the guideline registry of more than 16,000 patients with heart failure reduced ejection fraction admitted with acute heart failure, you see that the initiation or continuation of ACE inhibitor or ARBs, as shown in the blue and green curves, was associated with lower mortality and readmissions. And in fact, in those patients with acute heart failure who are eligible but not started on ACE inhibitor or ARB, compared to those who had in-hospital initiation of these agents, there was a 28% increased risk of mortality and 12% risk of increased readmission. How about angiotensin-neprilysin inhibitor initiation in acute heart failure? And this is what Pioneer HF study looked at. More than 800 patients with heart failure reduced ejection fraction randomized to in-hospital initiation of sacubitril valsartan versus enalapril. And they showed a 29% reduction in the NT-proBNP levels at 4 and 8 weeks from randomization with the in-hospital Entresto initiation. And the greater reduction in your NT-proBNP concentration with sacubitril valsartan was evident as early as week 1. And on the right-hand side, on the open-label extension study of Pioneer, there was significant reduction in your cardiovascular death and heart failure rehospitalization in patients who had in hospital compared to delayed sacubital valve start initiation with a number needed to treat of 13. What about, we talked about SGLT2 inhibitor evidence for augmentation of diuresis, but how about its use in acute heart failure patients outside of its decongestive effects? And this was studied in the IMPULSE trial, which randomized 530 patients with acute heart failure after stabilization, 1 to 4 days after hospital admission, irrespective of their diabetic status, to empagliflozin versus placebo. And they found a significant improvement in the primary endpoint of composite death, number of heart failure events, time to first heart failure event, and improvement in symptoms after 90 days of treatment with in-hospital initiation of empagliflozin. And acute heart failure patients treated with empagliflozin were 36% more likely to obtain clinical benefit compared to placebo. So one of the questions that frequently come up with the evidence I presented is that can we really initiate all these great therapies that you're talking about, foundational therapies in hospital during an acute heart failure episode, and is it safe to do so? So this was exactly what it was studied in the STRONG-HF study. It addressed the question of this question by randomizing more than 1,000 patients who were admitted with acute heart failure to intensive guideline-directed medical therapy initiation in hospital with rapid up titration, with aim of patients being on at least half of their optimal doses of guideline-directed medical therapy at discharge versus usual care. And what they showed that there was a 34% relative and 8.1% absolute risk reduction in the 180-day readmission for heart failure all-cause death, with no significant increase in serious adverse events in the high-intensity GDMT group with all the foundational therapies started in hospital. So at the beginning of this talk, I discussed decongestion strategies and some novel decongestion methods. And although some of the studies that I talked about, they suggested new approaches in treating and augmenting an effective decongestion and improving symptoms, but none of the diuretic pharmacology or strategy trials that I talked about, improved the hard clinical outcomes of heart failure readmission or cardiovascular mortality. So why are we not seeing this improved long-term results and clinical outcomes with enhanced decongestion strategies? The reason is that all our diuresis efforts in turn leads to sympathetic activation and neurohormonal activation. And what we know is that RAS inhibition is a cornerstone of heart failure management that we can achieve with our guideline-directed medical therapy. And as I discussed now, many of the recent trials have shown the early benefits of initiation of guideline-directed medical therapies in patients who are admitted with acute decompensated heart failure. So really what we need to do is to combine our efforts with enhanced decongestion strategies with enhanced and early guideline-directed medical therapy initiation and optimization in hospital. So the old approach of managing patients with acute heart failure, as I was going through training was, you decongest them, start them on 1 or 2 drugs of foundational therapy, and then you defer the rest of the therapy to an outpatient setting. But this has been replaced in the recent years with a current approach of starting all foundational heart failure therapies in HFrEF patients, the quadruple therapy of SGLT2 inhibitor, ARNI, MRM beta blocker in hospital prior to discharge. And you can really, choose what, kind of sequence you want to do. There's really no difference. I personally start with SGLT2, RAS inhibition, MRAs, and then I add beta blocker, the last agent, depending on the state of the presentation of the patient. And why is it important to start all these medical therapies in hospital? Number one is the clinical benefit of all guideline-directed medical therapies are apparent within 30 days of initiation, with a cumulative staggering 73% reduction in the risk of death with early initiation of quadruple therapy. And if you defer initiation of guideline-directed medical therapies in hospital, this carries the risk of these medications never being started as outpatient. In fact, 70% of patients who are not started on these agents are not started on in hospital, are not started on it as outpatient. Also, in hospital initiation increases the adherence, with studies showing that patients who initiated on guideline-directed medical therapy as inpatient had a higher likelihood to stay on it as outpatient. And in hospital initiation of guideline-directed medical therapy actually enables tolerance of other therapies. These medications are complementary. Medication like Entresto has less risk of hyperkalemia than your usual ACE inhibitors or SGLT2 inhibitors. They actually reduce the risk of hyperkalemia. So you can use other agents like MRA in these scenarios. So these medications actually work with each other so that most patients can tolerate them. I talked a little bit about pharmacological therapy in acute heart failure. I want to kind of shift now focus and discuss the role of IV iron in acute heart failure. And as you probably have heard, there's been a lot of interest in the role of intravenous iron in patients with heart failure, and guidelines suggest consideration of IV iron to improve heart failure symptoms and reduce the risk of heart failure admissions in patients with acute heart failure. And there's been many studies in the past year that have looked at IV iron in patients with both acute and chronic heart failure. This was a recent meta-analysis of 14 randomized trials of IV iron in heart failure, which included more than 6,000 patients, that suggested that treatment with intravenous iron reduces the risk of both cardiovascular death and heart failure-related events in a broad population of heart failure, including acute heart failure patients. And as you can see, a total heart failure hospitalization was reduced by 26% with IV iron. And in this meta-regression, what they also found was that the patients who had a transferrin saturation of less than 20%, regardless of their ferritin levels, derived the most amount of benefit. So my practice is that IV iron is generally well tolerated. It's quite difficult to access it as outpatient. So if you have a patient admitted with acute heart failure, check their iron indices. And if the iron indices are compatible with iron deficiency, give them IV iron before you discharge them from hospital. So I talked a lot about kind of importance of initiation guideline-directed medical therapy in hospital for acute heart failure patient. But the question is, what proportion of our patients who are admitted for acute heart failure are actually eligible for guideline-directed medical therapy initiation in hospital? And while I was at UBC, we looked at the guideline-directed medical therapy eligibility in acute heart failure in the Canadian Heart Failure Registry of 809 patients with admissions for heart failure across multiple centers across Canada. And as you can see in the red bars here in this graph reflecting patients who are eligible, the eligibility for guideline-directed medical therapy is actually quite high in our acute heart failure admissions. In HFrEF patients, 74% are eligible for Entresto start in hospital, 84% are eligible for MRA start, and 89% are eligible for SGLT2 inhibitors. And we further looked at, in terms of percentage of patients with acute heart failure who have heart failure with reduced ejection fraction, who are actually eligible for in-hospital initiation of all components of quadruple therapy. And as you can see on your right-hand side of the screen, we saw that on average, 72% were eligible to be started on all 4 therapies in hospital before discharge. However, when we looked at the prescription rates, we found really large gaps between the eligibility and prescription rate of guideline-directed medical therapy in hospital and patients with acute heart failure admission. You see that only 6.6% of patients eligible for Entresto, or only 44% of patients eligible for MRA, were actually prescribed these agents at the time of hospital discharge. And I understand, again, there are some barriers in terms of coverage for these medications, but again, these are quite alarming gaps. So despite kind of recent high quality evidence to support guideline-directed medical therapy use in acute heart failure, these have been suboptimally implemented. So we really need to adopt some implementation strategy using kind of evidence-based theories and frameworks to identify approaches that facilitate the uptake of medical therapies in acute heart failure and bridge this gap that we've seen. And really the approaches in terms of closing these gaps have mostly proven to be ineffective. And those that have been effective have not been consistently instituted. And one of these, the focus in acute heart failure care now has changed from pharmacology now to strategy trials so that we can enhance the uptake of evidence-based care. And this was one of those strategy trials in acute heart failure, the PROM-HF, which was used a pragmatic electronic health record best practice alerts to improve guideline-directed medical therapy uptake in hospital. This was a cluster randomized trial at the level of the providers, where providers were randomized to receive best practice alerts for patients with heart failure reduced ejection fraction to initiate or titrate the dose of the guideline-directed medical therapy based on the patient's profile, lab, or baseline medications. And for the primary outcome, they saw that there was 41% increase in the number of GDMT classes at 30 days in the alert arm compared to the no alert arm. There was also 39% increase in dose of the current guideline-directed medical therapy medications or start of a new class in the patients who who their providers received the alerts, electronic health alerts. And overall, the physicians strongly agreed that the best practices alerts were helpful in terms of improving the guideline-directed medical therapy regimens. The other major deficiency in our acute heart failure care relates to transitional care as patients are discharged and transition from hospital to home. We actually looked at access to heart failure care post-hospital discharge using the heart and stroke resources and inventory data. So in almost 500 Canadian hospitals who have more than 100 admissions with a primary diagnosis of acute heart failure, we saw quite limited and inconsistent access to heart failure clinics for patients after hospital discharge. So in 28% of centers across Canada or 30% of centers across British Columbia who admit or manage relatively high volume of heart failure patients, there's no established multidisciplinary heart failure clinic to follow up these patients post-hospitalization. And even if there's a heart failure clinic available, the majority have a wait time beyond 2 weeks, and in fact, more than 4 weeks for patients to be screened, to be seen after hospital discharge. Whereas guidelines recommend that these patients with acute heart failure need to be seen within the first week or two after discharge to prevent rehospitalization. So there's been, again, some strategy trials to test transitional care approaches to support acute heart failure patients as they are discharged from hospital. And PACT-HF was a Canadian-led study and one of the major strategy trials of a patient-centered transitional care. And their model comprised of nursing-led self-care education in hospital, a structured hospital discharge summary, a follow-up with a family physician within a week, and for high-risk patients, a nurse home visit or heart function clinic visits. And among more than 2,500 patients hospitalized with acute heart failure, they saw no improvement in heart failure hospitalization, ER visits, or death in the intervention arm at 3 months. However, a structured transition care program improved the secondary outcome of discharge preparedness and patients' quality of life. So our work with heart and stroke data that identified gaps in access to care for our hospitalized heart failure patients after hospital discharge made us to devise this SMS-HF pilot trial, which is a 2-year pilot randomized controlled trial of a mobile health strategy using the Welltel mobile health platform to support transitional care in patients with acute heart failure. And the Welltel mobile health platform, as some of you may know, has been used in different healthcare settings, both locally and internationally, and uses a 2-way text messaging kind of service. And I'm presenting this pilot trial here in hopes of, kind of motivating you all to recruit, these patients, as we roll out this pilot study. So we plan to randomize 96 patients with acute heart failure at the time of hospital discharge with a follow-up duration of 180 days. And our intervention comprised of 4 types of periodic text messages with patients that they will receive after hospital discharge. This will be focused on health check-in, vital sign reporting, heart failure education, and medication support. And the health check-in, basically asks patients, how are you doing? The patient might respond okay or not okay. And if they give a negative response, the system automatically will ask them to describe their symptoms. And based on the symptoms they report, the system, the automated system will flag the response and let the provider know to triage it and contact the patients. And also similarly for the vital signs, patients will be asked to provide their vital signs. And if there's an abnormal trend or value in terms of the vital sign, the system automatically flags and reports to the healthcare provider and research team to contact the patient. And we will be stratifying patients based on their acute heart failure risk score. If the patients have higher risk, they will be receiving more frequent messages. And there will also be a targeted education part in this pilot study with earlier post-discharge content focusing on common symptoms, warning signs and heart failure zones to reduce readmission risk, and later messages shifting focus from acute to chronic heart failure disease management and comorbidities. And lastly, again, I want to finish off with, again, something that I'm passionate about in terms of when to refer these patients for advanced heart failure therapy. Again, one of the main objectives of my talk is really to stress you the point that you already know that heart failure is a spectrum, and patients really move from one stage to the other. Heart failure is a disease state that waxes and wanes. And the presentation is more gradual these days. People are on neurohormonal blockade, they're on good diuresis, and this has all altered the milieu of the patients that we see in hospital these days. And I would argue that there's a good amount of our hospitalized patients with acute heart failure that if we do hemodynamic profiling they are in a kind of a pre-shock or a low output state. And when I say cardiogenic shock, all of us, kind of think about, patient in extremis with multi-organ malperfusion, after a large acute, myocardial infarction. But heart failure shock is something that is more subtle and present, and patients might present just a little bit more congestion, NYHA class 4. They might have a little bit of AKI. They might become more hyponatremic. They can't tolerate their GDMT, so you're removing their Entresto, you're removing their beta blocker. And, they have, been admitted to hospital for the second time in the past 6 months. So really, we need to pay attention to these patients more closely and create strategies to identify these heart failure patients before they decompensate so we can intervene in a timely fashion. And, the reality of this is, many of the referrals that we get these days for advanced heart failure therapies is too late. It's when the patient has progressed to refractory shock or they've progressed to multi-organ failure, and either they wouldn't be eligible for advanced heart failure therapies, or you have to kind of consider multi-organ transplant, which, as we all know, has poor outcomes. So there's what I call a golden window for referral for advanced heart failure therapies that occurs when you see a patient, in your clinic that is persistently symptomatic. You have to peel away their guideline-directed medical therapy, or a patient who is admitted on your floor with a second heart failure hospitalization in the past year that is not yet in shock, but might be showing signs of low cardiac output. And I use the mnemonic, I need help for referral for patients for advanced heart failure therapies. So if your patients have ever, kind of ended up at inotropes, that's a sign. If, their NYHA class 4 and their NT-proBNP is through the roof, if they're now showing signs of, kind of liver involvement, hepatic congestion, renal failure, that's the clue. If they have severely reduced ejection fraction, I say less than 20%, that's the clue. They're having more arrhythmias, they're getting ICD shocks, they've been admitted more than once in hospital in the past years. You started with Lasix 40 milligram daily, and now they're on 120 milligram BID. That's another clue. Their blood pressure are softer, systolic is 80s without any guideline-directed medical therapies. And, now you're removing their prognostic medications like your guideline-directed medical therapies because of their renal function. So these are all clues that these patients need advanced heart failure therapy. And why do we need to refer them to our advanced heart failure therapies early? The reality I want to stress is that we have come a long way in managing our patients with advanced heart failure in the last decade. We have so many durable options to help our end-stage heart failure patients than inotropes these days. I think of inotrope as a transient tool to get patients out of trouble, make them feel better. But we all know that inotropes don't prolong life. But we have come a long way with our technology. For instance, durable left ventricular assist device. The median survival on an LVAD device now is 7 years. There are some associated risks with it, like stroke, GI bleed, RV failure, but overall rates have substantially decreased with this newer generation LVAD devices. And we have come a long way in terms of our heart transplantation. People live on average 13 to 15 years after heart transplant, despite some short-term and long-term risk. And I think many of you know what kind of durable left ventricular assist devices are. Basically, there's an inflow cannula that goes to your LV with the outflow that goes to your ascending aorta and continuously pumps blood forward in patients with end-stage heart failure. And if you look at the 5-year outcomes of the Momentum trial that looked at over 1,000 patients randomized to the newer generation magnetically levitated centrifugal flow HeartMate 3 LVAD, compared to the previous axial flows that we had at the HeartMate 2, we see a survival of 58% at 5 years and a median life expectancy of 7 years with HeartMate 3 LVAD devices. And I think, it's I want you to know that these are the patients that were majority implanted with LVAD as destination therapy. That means that they were not a candidate for transplant because of their comorbidities. They were older, above age 65 and 70. Despite all those, these patients lived on average 7 years, which I think is great. And this is data from International Society of Heart and Lung Transplantation, looking at heart transplant outcomes at different decades. And you see that in early 2000, the median survival of transplant was 13 years. But with expansion of recent novel organ procurement strategies, targeted immunosuppression, we have non-invasive way to monitor for rejection now with blood work. We can only expect that the post-heart transplant outcome is even going to increase beyond 15 years. And I really can confidently say that there's no therapy in advanced heart failure that would offer such longevity for patients outside transplant. So it's really important to refer these patients timely for consideration of these therapies. So with that, I want to conclude my thought. I hope that I kind of conveyed the message that acute heart failure is on the rise. It's associated with increased morbidity and mortality. That congestion is a tipping point for acute heart failure, and treat congestion aggressively. Don't be afraid of renal dysfunction. Although, again, to some degree. And consider sequential nephron blockade. Urine sodium is a nice strategy to kind of optimize your diuresis goals. And think outside the box. Think about other agents, hypertonic saline in your diuretic-resistant patients. Really try to initiate all foundational guideline-directed medical therapies early in hospital and prior to discharge after stabilization of acute heart failure episode. And really focus on kind of strategies that you can help these acute heart failure as they transition outside of hospital. And again, lastly, refer these patients for advanced heart failure therapies early in the course of their journey. If you're seeing they're having signs of end organ dysfunction, you're taking away their medical therapy, or they've been hospitalized for multiple times, I think those patients need referral. So with that, I want to thank you, all of you, for listening and giving me the opportunity to talk today. I'm happy to take any questions.
So one of the advantages of being around a long time is to look at, I thought you were going to speak about a bit different intervention. So all of you won't know, but when I graduated from medical school, the treatment for acute heart failure was very different. We did have loop diuretics at the time. So I was in the pharmacology era, but patients came to emergency with acute heart failure. We would use rotating tourniquets and intermittent positive pressure ventilation and narcotics. Now, it sounds ridiculous, but in some senses, it decreases the volume and the flow. So nothing's new, but everything's new. And then I thought, hypertonic saline for someone in heart failure, if any of us walked in and saw that, we'd think, my God, what are you doing? So thank you for the Jeremy and for the presentation. Questions? Anybody online want to ask Nima any questions? If not, I'll open it up to the audience. Any questions here? Thank you.
The algorithm there that you had earlier for like augmenting your diuretic. In practice, you often see people using metolazone despite some of the adverse effects that you mentioned in some of the literature. So do you practically you just go straight to Diamox for augmentation?
Not really. I think that's a great point. I use metolazone not uncommonly too in our patients. I think sometimes we reach for metolazone too early without maximizing your loop diuretic. And I think that's why kind of using some strategies as your urine sodium comes handy, because we get 80 of IV Lasix or 120 of IV Lasix, and we then put our hands up and use metolazone. But I think sometimes again, I've used very high doses of loop diuretics. I've used up to 30 milligram per hour of Lasix infusion in patients. To get the adequate natriuresis. So I still use metolazone, but again, I kind of try to optimize, my loop diuretic first. And depending on, if the patient is really hyponatremic, and, a lot of advanced heart failure patients we see are really hyponatremic, I try to kind of not use metolazone up front and use kind of some of the other strategies. I want to talk a little bit about that tourniquet. And I wanted to include a slide about tourniquet because it's exactly what we do. I think, all these studies that I talked about, kind of preload, afterload, decongestion is exactly what tourniquet did. Kind of you inflate it, reduce your pulmonary capillary wedge pressure, vasodilate them. And I think we are just doing an extension of that. So we're going full circle.
It's just in addition to your talk.
Exactly, yes.
I think there's somebody I'm sorry, I can't see. Is there somebody online?
Yeah, I wanted to ask a question. Hi, Nima. Thank you so much for the great talk.
Thank you.
The last time I was on CTU, the last 3 times, we had a number of patients admitted with acute exacerbation of heart failure with reduced ejection fraction. And we wanted to start all of the GDMT while they were in hospital. But for us, I recall blood pressure being a big deal and symptoms. When we thought we had, diuresed them reasonably, they were on room air, but we had a hard time getting all of the medication on board because their systolic was like between 85, 90, and they were dizzy and symptomatic. So I just wondered how might we approach those challenges with some of our patients? Thank you.
Yeah, that's a great point, Dr. Palpu. So again, that's, I think, a big challenge. The way I think about, kind of medication, I think we have to individualize, how we approach and start these therapies in patients. If the patient is hypotensive, I usually start off with SGLT2 inhibitors and MRAs. They have the lesser effect on your blood pressure. And then, kind of put the your ACE, ARB, or ARNI and beta blocker towards last, give them, a little bit of time in terms of other agents before I started them on. Some stuff that I, commonly do as stagger medications. I, kind of don't give them at the same time in the morning, stagger them by 1 or 2 hours, give the vasodilators maybe later in the evening. So the effect is a little bit less, kind of give the diuretics with the medication with diuretics in the morning, the vasodilators more in the evening. And, believe it or not, I, as a heart failure kind of doctor, I sometimes shouldn't say this, but I use baby doses of medications. I kind of use this whiff of medications at times so that they're on. I kind of minor dose, Entresto 12, 13 milligrams twice daily, just a tiny bit so that they're on. And usually, again, my experience is that with time, people adapt to these medications. It's just, I think it's good to start them, even as I said, baby doses, kind of placebo doses so that they're on, so that we can build up on later. But the reality is that, and I think if there's patients that we have whose systolic is 80 and we cannot put any guideline-directed medical therapy, that's a sign for me that this patient might not thrive on medical therapy. And this is a patient I would refer to heart failure and kind of for consideration of advanced therapies if they're a candidate. Again, if the patient's 85 with comorbid, definitely not. But if it's a younger patient and we're struggling to put them on kind of these life-saving medications, I think is a sign.
I like your strategy. Those are all really practical suggestions. Thank you so much.
Thank you.
I'm sure there'll be questions for Nima later, but I wanted to thank him on behalf of the group. Thank you very much.
Thank you so much, sir.